This study is a randomized controlled trial looking at patients with low back pain with or without contemporary leg pain and their episode of care and outcomes over 2 weeks. So it feels like it was from a long time ago, but it's from 2004, published in the journal Spine. Authors were Audrey Long, Ron Donaldson, and Fung. I've mentioned Ron Donaldson before. He is the author also of Rapidly Reversible Low Back Pain. So the title of this study was Doesn't Matter Which Exercise, a randomized controlled trial of exercise for low back pain. And there's a lot of complaints that there aren't great randomized controlled trials, especially those that look at patients undergoing repeated movement testing as part of the McKenzie method. And this is one that we have that we can look to for information when it comes to whether or not using repeated movement in a specific direction actually can confer some benefits to patients or not. So the inclusion criteria, the patients they were looking for, low back pain with or without leg symptoms, and plus or minus one neurological sign. So there's a lot, also 18 to 65 in terms of age, and they had to have a directional preference. So when they did repeated movement testing as part of the orthopedic evaluation on day 1, they needed to find that there was a chance or proof on day 1 that the patient likely could respond to movement in one direction. And then, as I was going to say, there were lots of exclusion criteria, for example, post-surgical or non-musculoskeletal, like inflammatory or cauda equina. And that makes sense. We don't want to ask, does a person with cauda equina need movement in a specific direction? They need emergency care, right? And inflammatory patients need anti-inflammatory care. So that is the starting point for the patients. They used 11 clinics. They used physical therapists who had extensive MDT training. So extensive training in the McKenzie method and using repeated movement testing as part of the orthopedic evaluation. These clinicians have been certified or diplomaed in the McKenzie method, the 2 levels of training, on average for 3 years. So what I like they say in the introduction that kind of spells out where we're starting from is, quote, previous studies have shown that exercise promotes healing, can help control pain, and improve function. However, there are a variety of opinions regarding which exercise or exercises is the best, unquote. And that's true. Most of us will agree that yes, encouraging activity that's not severely increasing one's pain, doing some exercises is a good first-line treatment for low back pain. But I would say we don't quite have enough competition in the world of medicine. And part of that is because of our situation where, if you're the provider and insurances just shuttle you people, where's the kind of outside incentive to be better? And so I think that there are better treatments than others. And that's what I strive to do as a clinician, is provide the best treatment. I'm not trying to provide treatment that works. I'm trying to provide treatments that's the best. Gets people better as fast as possible, reverses disorders as fast as possible with the least amount of risk, etc. So that's the jumping off point for where this study is coming from. Is there a difference between which exercises we give people? And an analogy that I use that I know some people don't like is that if someone has chest pain, you don't give them all the same intervention. You give them an antacid if the problem is a heartburn related issue. You give them cardiac surgery if they have an emergent problem with one of their heart arteries. You give them a corset or a brace if they fractured their rib. Chest pain, just like low back pain, is a symptom. It's not a disorder, it's not a diagnosis, and there are different things that create low back pain. As we can tell from the exclusion criteria, we make these obvious examples, like cauda equina is a very specific reason why someone has low back pain, or inflammation, or a fracture, or an infection, and those are very specific. And many clinicians in the world of orthopedics would argue that those are very specific conditions of low back pain that create low back pain, but then there's this whole other group of non-specific low back pain. And what I would rebut is that this huge group of non-specific low back pain, as this study goes into, are not that non-specific. There are specific disorders within that group that makes them heterogeneous. For example, people who respond to movement into flexion, or people who respond to movement into left side glide, or people who just need strengthening. There are different groups, and this non-specific low back pain is not as non-specific as we think. And that's part of the topic that this study addresses. Another example besides chest pain would be a fever, right? You don't attack a fever, which is a symptom, the same if it's a bacterial infection or a viral infection or heat exhaustion or a tumor. They're very different pathologies that create the symptom of a fever, and they need to be addressed differently. And that's what I find with low back pain as well. It's a symptom. I'd like to get to the root cause as much as I can and provide the very specific matched treatment to that individual patient's root cause of why they have low back pain. So the study looked at 312 patients, and when they evaluated them using repeated movement testing, again as part of the first orthopedic evaluation, they found that 230 demonstrated a directional preference. So 230 of the 312, which is 74%, showed evidence by using the repeated movement testing that one movement was likely best for their low back pain disorder, which when we combine directional preference for their treatment, or use directional preference for the treatment, the term we use is joint derangement. They have a joint derangement responding to XYZ, but we could just be more vague and say they show a directional preference. They show that one exercise is better than another. And then the other patients, 26%, did not have a directional preference. So they were not included in this study. Now, that 74% jives with what I say a lot, which is 70 to 80% of patients I find can move into a specific direction or two and resolve their disorder. And that's consistent with the literature. It's also consistent with what I see in the clinic. There's going to be a group of people who don't, and we apply the matched treatment for those patients as well. But this matched treatment, the directional preference, then further kind of divides into which specific direction for the repeated movement is most appropriate for that individual patient. So when they did the testing of this 230 people, 191 showed a preference for extension of the low back, which also included in this cohort extension with hips off center. So extension with a little bit of a lateral shift or component to the exercise. Flexion was only 7% of patients, so forward bending was the direction that was most efficacious for only 7%. And then 10% of the patients, 23 in total, showed a directional preference for lateral movement. That could be left side glide, right side glide, left rotation and flexion, or right rotation and flexion. Now, this is where they started the randomization. They took these groups of people and they randomized them. And they said, okay, so maybe our repeated movement testing on day one shows that you have a directional preference to reverse your pain and disorder with extension. Some of those people got extension. Some of those people got the opposite, so flexion. And some of them got evidence-based care, which is what a lot of clinicians do prescribe for non-specific low back pain. And that does vary from clinician to clinician because there are different theories and different ideas out there. But in general, what they did here is kind of what a lot of clinicians do, which is multi-directional movements, mid-range lumbar mobility stuff, and hip and thigh muscle stretching. So they had 80 participants in the matched group, 70 participants in the opposite treatment group, and 80 in the evidence-based group. They used clinicians, again, who knew MDT, who knew repeated movement testing, but they were instructed to, not tell the patient their directional preference because they don't want to tell the patient, oh, you respond to extension on day one and then give them flexion. They didn't want that bias, obviously, and they wanted to use the clinicians who could say, we're doing this and we believe you're going to get better, because there is some literature, or there's a lot of literature out there that's saying, yes, people do get better with their low back pain, especially if it's acute, right? It'll go away. But as I mentioned before, the question to me is not necessarily, will the pain go away? Because that's kind of a given in most people. My question is, has the disorder reversed? And does the patient have the tools to minimize the disorder coming back, minimize recurrence? They had 29 dropouts on the whole, and they separate those from people who are actually withdrawals because of getting worse or no better or peripheralization of symptoms. So peripheralization of symptoms is when patients experience pain that moves further from the spine. So if it started as buttock pain, for example, moves into the calf, or if it starts as low back pain, now it's in the buttock. So the dropouts were for various reasons, but the withdrawals were for patients who were, like I said, getting worse or not seeing improvement or getting worse via peripheralization of the patient's symptoms. Now, this is kind of a big number when you consider that the test or the experiment was only run over 2 weeks. They needed a minimum of 3 visits, a maximum of 6 visits over the course of 2 weeks. Now, when they looked at outcome measures, they took them at initial evaluation and they took them at 2 weeks. And they looked at many different outcome measures. The primary outcome measures were pain with a visual analog scale, the Roland-Morris, which is a disability questionnaire, and thirdly, medication use. And then the secondary outcome measures were work-home interference. So they had a questionnaire about how much their work life or their home life was interfered with, the Beck disability inventory, the Quebec Task Force questionnaire, and they did a questionnaire about satisfaction with care, basically, and satisfaction with improvement and returning to life at normal function. They did not, which is very interesting and makes sense, they did not use range of motion or strength testing or nerve tension testing as part of their outcomes to reduce bias. And that could be because if you come back to me on patient or on visit 3 and I do a nerve test and you can see that it's much worse than it used to be, or your movement's much worse than it used to be, that could influence your filling out of the questionnaires or your reporting of improvement or worsening. So they did not look at that. So they're looking more at what the patient is experiencing. These are subjective reports aside, well, medication use is relatively subjective too, but these are looking at what the patient is experiencing in terms of pain and function. And that's what most orthopedic studies are looking at, pain and function. And I would like to go a step further and really get a lot of information on what's changing with the range of motion, what's changing with the strength, and what's changing with the nerve tension. And that was not the focus of this study, but it's my opinion that I would love to see those parameters in all orthopedic studies. So then we could better understand, well, okay, the shoulder pain went away and the person was back to her sport, but did she regain full internal rotation of her shoulder? Did the person regain all strength in all planes of the shoulder, etc.? So those are the outcome measures. If we go back to the groups, here are the results. They randomized them to the 3 groups. And when we go back to withdrawals, which is kind of a potent indicator of whether or not someone's pleased with their improvement or not pleased with their lack of improvement, the matched group, so the people that responded to extension and were given extension, the people who responded to flexion and were given flexion, and the same with the lateral, there were no withdrawals in the matched group. In the opposite group, 38% of the patients withdrew. So that means, for example, someone who responded to flexion in the initial evaluation, but was told to do extension 6 times a day, for example. And then the evidence-based care group, 33% withdrew. So those are decent changes. No one withdrew when they were given the exercise that the clinician found on day 1 helped with the patient's pain and disorder. But almost a third in the other cases did. So that's a very profound finding. But overall, they found that all the outcome measures over the 2 weeks improved in all 3 groups. But there was a statistically significant improvement in the matched group in all of the outcomes compared to the opposite group and the evidence-based care group. So that says it all right there, is they found something statistically significantly better than the other 2 just by matching that patient with the one exercise they found with the repeated movement testing to be beneficial. Now, taking a step back, something I didn't mention is these statistics kind of bear out what we see a lot too, which is 30% of this group of 230, it was their first episode. So that means 70% of the patients, this was not the first time they had low back pain. And that speaks to what I notice all the time, is that patients are rarely having first episodes that I see them. Low back pain tends to recur. And my goal as a clinician is to really empower patients with the knowledge of what's going on and the ability to minimize recurrence so that they don't become a statistic where the low back pain keeps coming back, and tends to get worse with the more episodes the person has. Also, 35% of the patients were reporting there was no apparent reason why their back pain started. I tend to find it to be a little bit higher than that, but again, a lot of people are just having pain and they're not having an episode of acute injury. And also, this group of patients that they use, most of them were not having acute pain. They had pain for 6 weeks or longer. So when we find directional preference, some people would argue that, yeah, you're going to find that more often in people who have new pain under 6 weeks. But this study showed that a lot of people with subacute and chronic pain had a directional preference with repeated movement testing as well. So that covers the gist of this. This study can be found free online. I think it's on ResearchGate. It might be .net. And it lends credibility to what I see and what I do and find with patients, which is 70 to 80% will have one or two directions that can help with their pain and function. And I would further go to say that yes, their pain and function is better, and their range of motion is better, and their strength is better if it was lost, and their nerve tension is better if it was lost. And so if I find these people, then we can have a really good outcome, and we can have a maintenance or prevention program if the person says, oh, I understand, I didn't have enough extension in my life possibly, but I respond to extension now, so maybe I'm going to do extension once a week or once a day, or when I go to the gym and squat heavy, some plan to kind of keep their back moving well so that the incidence of recurrence is lowered. But please check out this study, and if you have any questions, let me know and I'll try to answer them.